Hello, welcome back. So today we are looking at physiotherapy in thoracic surgery. We've looked at the chronic obstructive pulmonary conditions as well as the restrictive pulmonary conditions. Now we are making progress. Today we are looking at it because some of those conditions would require some surgery at some point, and they will be referred to your department to physiotherapy so that you do some rehabilitation on them. So let us look at these conditions. So indications for surgery usually will be tumor, okay, amongst the conditions that cause surgery would be tumor, okay. The most common reason for pulmonary and esophageal resection is malignant tumor. These tumors classified into two main categories. Number one, small cell carcinoma, which is referred to, which usually accounts for about 20% of all the cases. Then there is what is known as a non-small cell carcinoma, which accounts for about 80% of all the cases, including squamous cell carcinoma and adenocarcinoma. Small cell cancer is virtually always widespread at diagnosis, so surgery is usually not an option, okay? Because it will avoid the spread, so there is no need for surgery. There you do other rehabilitation measures that are suitable for cancer. Okay, amongst other reasons, again, we have pneumothorax, which is the collection of air in the pleural cavity. It is usually occurs spontaneously and is caused by rupture of the visceral pleura of an otherwise healthy lung. So we know what pneumothorax is. It is usually a collection of air in the pleural cavity. So we talked about pneumothorax, and patients with chronic obstructive pulmonary diseases can rupture the pleura, resulting in pneumothorax. So there are quite a number of conditions that will result in pneumothorax. Okay, amongst them, again, we have empyema can go for surgery in the lung so that the lung tissue is opened, the affected area is drained of pus, because empyema is the collection of pus, okay, in the pleural cavity. So you open, you drain the pus from there, and the cause is commonly pneumonia, lung carcinoma, or lung abscess, okay, including bronchiectasis, and more rarely TB can cause empyema. Bronchiectasis is also one of them, which we talked about, okay? And we said it's a chronic lung condition in which abnormal dilatation of the bronchi occurs associated with obstruction and infection. So there could be need to open the lung tissue, chest wall lung tissue, and access the affected area and drain the pus. Okay, drain the pus or treat the infection or remove anything that is causing problem. Esophageal perforation, trauma and perforation to the esophagus may result from accidental swallowing of a foreign body, such as a dental plate or others that maybe esophagus can rupture. So all that as well can cause or can call for thoracic surgery. Preparative investigations, patients are assessed preoperatively in order to establish the nature of the lesion and whether they are fit for surgery. So preoperatively, it's very important that you understand the condition, the nature of the lesion, and you assess whether the patient is fit for surgery through a lot of other tests that are commonly known as lung function tests. You conduct one or two of those tests, and come up with a thorough assessment, which will give recommendations to the operating team as to whether this patient is ready to undergo surgery. Okay. Chest x-rays can be taken, CT scans as well as PET can also be taken to ascertain the nature of this lesion and exactly what it will take for this surgery to take place so that you have a full understanding of what you are subjecting the patient to. And you prepare yourself beforehand so that when the patient, immediately the patient comes from surgery, you already know what is likely, what they are likely to present, and you have already prepared for them adequately. Bronchoscopy, esophageoscopy can also be done to confirm all those things. Pulmonary function tests, okay, will help the surgeon to decide whether the patient is able to withstand this resection. Arterial blood gases are analyzed routinely in some hospitals, but they're very important so that you understand how this patient has been managing or the saturation, oxygen saturation of this patient so that you can be able to understand or to get the full picture of what is likely to come up after the surgery. So let's look at the types of thoracic incisions that we are likely to find. Posterolateral thoracotomy, which is an incision through the fifth or sixth rib, which is used for pneumonectomy or lobectomy. So these are some of the conditions which happen in the chest wall, and they happen in the chest wall. And because the chest wall, we all understand, is made up of muscles and the rib cage, at the end of the day, there will be movement that will be that will come in, that will be affected. Okay, so muscles such as the trapezius in this type of incision, muscles such as the trapezius, latissimus dorsi, rhomboid, serratus anterior, and the corresponding intercostal muscles will be affected. So these are the muscles that cause movement. So meaning with this kind of incision, you have to know the movement that those muscles do, which we have already done, and and have an idea of where you're supposed to start from, what kind of movements you're supposed to emphasize on, and how to teach your patient both pre and post-operatively, how to prepare your patients. Anterolateral thoracotomy, this incision is used primarily for cardiac surgery, but can be used to perform plurectomy, okay? Can be used to perform plurectomy, and these are the common incisions that we are going to find, okay? These are the common incisions that we're going to find. This is the one that is referred to as anterolateral thoracotomy. Then this one is referred to as posterolateral thoracotomy, and here we have median stenotomy. All of these are performed to achieve different different ends or to treat different conditions. This incision, like median stenotomy, is used for lung volume reduction surgery and bilateral plurectomy. It is vesical incision that involves the splitting of the sternum, just as we have seen. So you get to understand that each different conditions will call for different thoracic incisions with different post-surgery interventions that are required by a physiotherapist. Left thoracolaparotomy is an incision used for surgery in the lower esophagus and the stomach. It involves the latissimus dorsi, serratus anterior, and corresponding intercostal and abdominal muscles, which we understand what the function of each of those muscles that are involved. And this is how this incision is going to look like. Thoracolaparotomy, so it is coming from the thoracic going into the abdomen, okay? Then operations on the lung, we have the common ones. We have the one that can be called sleeve resection of the upper lobe. So the upper lobe can be resected depending on the presentation. If the lung tissue has to be removed, so it could either be the lower upper lobe goes, okay, the middle lobe goes. All those lobes can go in what is known as the lobectomy. Okay, pneumonectomy. In pericardial pneumonectomy, it is carried out for tumors involving the main bronchus. So anything that is involving the main the respiratory tract, the rib cage, and the contents thereof would call for, if it is calling for surgery, it would go for a specific type of surgery which you are supposed to know. The lobes can be removed, and every structure that is affected can be removed, and that will go for surgery, which the patient will have to come to you for treatment. Okay. Segmental resection can also happen, wedge resection can also happen, and there are those type of surgeries that are known as lung volume reduction surgery. So this is the type of surgery which is designed to improve respiratory function in patients with severe dural emphysema. So we learned in emphysema that emphysema, there is air trapping, okay, permanent dilatation and air trapping. So you find that there is formation of dura. That dura would be removed by surgery, and usually the type of surgery that these patients will undergo is referred to as lung volume reduction surgery. And these patients present with hyperinflated lungs and flattened diaphragm. So this would be the ideal surgery for them. It has to reduce the volume. So all those conditions we talked about, we talked about air trapping and causing the diaphragm to be flattened. They'll be treated through surgery, and this is the type of surgery. Therefore, patients should undergo a period of pulmonary rehabilitation preoperatively to maximize their respiratory functions. However, this can also come with some kind of complications. Okay, there's nothing that you cannot rule out the possibility of complications anywhere. So you have to actually understand that there could be complications so that you know how to prevent them. You anticipate the type of complications that are common in the procedure that you want to do and know how to intervene and how to prevent them. Okay, major complications of the pulmonary surgery will include respiratory. If they are respiratory, it can bring about and atelectasis, collapse of the lung tissue. It can bring about pleural effusion, okay? Can bring about surgical emphysema as well as respiratory failure. So make sure that all those things are taken into consideration so that you avoid them as much as you can. Circulatory, if the problem is circulatory, it can also bring about deep vein thrombosis, myocardial infarction, or an emboli, okay? Arrhythmias can also arise. Atrial fibrillation will occur in approximately 30% of lung resection patients. So with that high number, it means you really have to be alert on that one and see to it that it is prevented. A wound may be infected, chronic wound pain, or failure to heal. You know, there is no surgery without a wound. A wound will have to be there, and if it is infected or fails to heal, it is a complication. Or maybe during the operation, you can cause injury to the nerve. Okay, the nerve may end up getting damaged where it can end up actually damaging even the nerves that supply the vocal cords. And all these are complications that would arise, and people are supposed to be aware of them. Okay. Physiotherapy and other management. Preoperative physiotherapy, you are trying to see a patient before surgery can be very beneficial. Okay. However, it can be difficult if the case is an emergency, as there will be no time for all those preparations. But a preoperative assessment may include the explanation of the role of the physiotherapist in the team. You know, you're not going into this procedure alone. You're working in a team and everyone is there. So you have to make your presence known and in the team, and the possible risks of surgery and the effects of the general anesthesia. All these have to be explained. And your role, what will your role be as a physiotherapist there? What will you be doing? Okay, what will happen after surgery? You have to make all this clear both to the team and to the patient that you are dealing with. Some of these benefits to seeing a patient preoperatively may include to reduce the patient's anxiety. Levels of confidence will be gained. The patient should have confidence to know that there is even life after that big surgery that they are about to undergo. The patient will have more knowledge on what is entailed before, during, and after the surgery, and can prevent the risks of developing postoperative pulmonary complications. You cannot do the treatment alone, okay? Treatment has to be done in concert with the patient, and the patient, once the patient is supportive, you receive full cooperation of the patient, the rehabilitation will be very smooth, okay? After the surgery, the main problems found on assessment of a patient who has had a major surgical procedure is reduced lung volume. This could result in impaired gas exchange and airway clearance. Therefore, the aim of a physiotherapist is to try and improve these problems. Okay? You will try to improve these problems. Amongst the interventions that you are supposed to do as a physiotherapist, you should consider mobilization, because mobilization will improve lung volume, to improve circulation. It will decrease their stay in hospital, as well as aid in the removal of secretions. Okay, for example, you can train them walking, being ambulant. In other words, they should be as ambulant, they should be ambulant as early as possible. Okay, positioning. Make sure that you change positions regularly, so that you help in moving secretions. Deep breathing exercises are very important and can help re-inflate the collapsed lung. With surgery, more emphasis is on deep breathing component rather than on forced expiratory maneuvers to avoid pain and discomfort. Holding the breath and sniffing at the end of inspiration will help expand the lung tissue. This will help sniff at the end of the inspiration and hold a bit, will help to maintain the volume of the lung tissue, and that is what you want to achieve. Among other means that you can use continuous positive airway pressure, intermittent positive pressure, and incentive spirometry. All these are procedures that can help postoperatively to achieve better results. Management of postoperative pain, it's very important that pain is managed. Otherwise, if it is not, nothing will work. The patient will not cooperate. Okay? Pain after surgery can hold a major effect on the patient's recovery. Some of the effects will be ineffective ventilation, poor cough, poor sleep, delayed hospital discharge. So you find that actually they will not even cooperate with you. If their pain can be managed, this may result in a reduced length of stay in hospital, reduced their length of rehabilitation, and their rehabilitation will be more efficient. Pain can be reduced through medication, education, careful handling, and relaxation. So these procedures can help in managing pain. So some of the drugs which your patient will be in could be either be oral, intramuscular. All of this information you're going to find it in the files of the patient. It is important that the physiotherapist is working with the patient when they are in least pain, so that they can get the best treatment. Therefore, it is recommended that the physiotherapist sees the patient 30 minutes after they have taken their medication. So this is about thoracic surgery, physiotherapy in thoracic surgery, and what we're expected to do. Thank you so much for listening.